One of the extremely important topics at present is the discourse on dementia. Dementia is often discussed casually and perhaps excessively, so I consider it appropriate to provide some explanations about this term, which may be used incorrectly. Dementia is essentially a progressive cognitive decline caused by various pathologies. Unfortunately, it has recently been asserted that one of these forms would be Alzheimer's disease, but in reality, there are several dozen pathologies that lead to dementia. Therefore, it is appropriate to delve deeper into this significant aspect.
Dementia is a progressive cognitive deterioration caused by a variety of pathologies, which will be listed below. First, it should be emphasized that the word dementia is a generic term that encompasses a set of symptoms without referring to a specific pathology. Among the various forms of dementia, which will be subsequently listed, Alzheimer's disease has become particularly widespread. It is a specific pathology with precise biological characteristics and, importantly, not a morbus, a term that indicates a disease with a fatal course of unknown causes. Even in common language, the term Alzheimer's disease or dementia, or simply Alzheimer's, refers to a person who presents a memory deficit significant enough to affect their daily life activities. Unfortunately, age-related cognitive decline, perhaps limited to a recent memory disorder, a very common condition beyond a certain age, is currently classified inexorably and inappropriately as Alzheimer's disease. It would be better to refer to it as cognitive decline. It is indeed necessary to emphasize that there is a significant difference between cognitive decline and Alzheimer's disease. It is important to remember, as mentioned above, that Alzheimer's disease is a disease with precise anatomopathological characteristics. To make a diagnosis of Alzheimer's disease, it is necessary to identify the presence of beta-amyloid plaques and tau tangles in the brain of the affected person through specific biomarkers. Consequently, it makes no sense to immediately classify as Alzheimer's disease a cognitive deterioration that may have other causes. Unfortunately, making a diagnosis of Alzheimer's disease in the presence of cognitive decline with involvement of recent memory is very common. Regrettably, this attitude is often present even among doctors. In fact, it is generally the family members themselves who diagnose Alzheimer's disease. The physician, sometimes even a specialist, often confirms the diagnosis of Alzheimer's disease. At this point, it is necessary to remember that Alzheimer's disease is a genuine disease not related to brain aging and has distinctive characteristics. To make an accurate diagnosis of Alzheimer's disease, it is indeed necessary to identify plaques and tangles in the brain and the presence of abnormal proteins, such as beta-amyloid or tau protein, through the use of biomarkers. Only in such cases can dementia be labeled as Alzheimer's disease. In reality, dementia can be caused by a variety of pathologies listed below that can lead to a form of dementia. Most cases are sporadic with late onset, at or after 65 years of age, and with unknown etiology. The risk of developing the disease increases with age. In 5 to 15% of cases, Alzheimer's disease is familial. Half of these cases have an early onset and are in some instances correlated with specific genetic mutations. At least 5 different gene loci, located on chromosomes 1, 12, 14, 19, and 21, influence the onset and progression of Alzheimer's disease. Mutations in the genes for amyloid precursor proteins, presenilin 1 and presenilin 2, can lead to autosomal dominant forms of Alzheimer's disease, usually with early onset. Mutations in these genes can alter the processing of the amyloid precursor protein, leading to the deposition and aggregation of beta-amyloid fibrils. There are also genetic factors, including some alleles of apolipoprotein E, APOE. Indeed, APOE proteins influence beta-amyloid deposition, cytoskeleton integrity, and the efficacy of neuronal repair. The risk for Alzheimer's disease is substantially higher in individuals with 2 epsilon 4 alleles and may be lower in those with the epsilon 2 allele. Vascular risk factors such as hypertension, diabetes, dyslipidemia, and smoking can increase the risk of Alzheimer's disease. Beta-amyloid is the main component of neuritic plaques, which consist of degenerated axonal or dendritic processes, astrocytes, and glial cells surrounding an amyloid core. Beta amyloid can also alter the activities of kinases and phosphatases, which in turn can lead to the impairment of tau protein, a substance that stabilizes microtubules and lead to the formation of neurofibrillary tangles. A sustained immune response and inflammation have been observed in the brains of patients with Alzheimer's disease. Some experts have proposed that inflammation is the third main pathological feature of Alzheimer's disease. It has been demonstrated that disorders of glucose metabolism play a potentially important role in the development of Alzheimer's disease. Prion have been identified in Alzheimer's disease. In prion diseases, a normal cell surface protein in the brain called the prion protein is misfolded into a pathogenic form defined as a prion. The prion then causes misfolding of other prion proteins, resulting in a significant increase in abnormal proteins, leading to brain damage. In Alzheimer's disease, it is thought that beta amyloid in cerebral amyloid deposits and tau in neurofibrillary tangles have self-replicating properties similar to prion. Symptomatology of Alzheimer's disease. The most common initial manifestation is short-term memory loss. For example, asking repetitive questions, frequently misplacing objects, or forgetting appointments. Other cognitive deficits tend to involve multiple functions, including the following. 1. Difficulty in managing complex activities and poor judgment. For example, being unable to recognize the value of money, making inadequate financial decisions. 2. Language anomalies, for example, difficulty finding appropriate words, pronunciation and/or writing errors. 3. Visuospatial anomalies, for example, inability to recognize familiar faces or common objects. Alzheimer's disease typically progresses and persists. Generally, the evolution of Alzheimer's disease is similar to other forms of dementia. However, despite clinical characteristics, specific laboratory tests, and imaging investigations, the definitive diagnosis of Alzheimer's disease can only be confirmed by histological evaluation of brain tissue. Generally, the diagnosis of Alzheimer's disease is similar to the diagnosis of other forms of dementia. However, despite clinical features, specific laboratory tests, and characteristic imaging findings, the definitive diagnosis of Alzheimer's disease can only be confirmed by histological evaluation of brain tissue. Recommendations for the diagnosis of dementia, including Alzheimer's disease, are available from the National Institute for Health and Care Excellence. The evaluation includes a complete history and standard neurological examination. Clinical criteria have an accuracy of 85% in establishing the diagnosis and differentiating Alzheimer's disease from other forms of dementia, such as vascular dementia and dementia with Lewy bodies. In some cases, other pathologies may be concomitant, for example, of a cerebrovascular nature. These findings increase the likelihood that dementia is due to Alzheimer's disease, although the use of cerebrospinal fluid biomarkers does not always yield reliable results. Laboratory tests, for example, thyroid-stimulating hormone, TSH, vitamin B12 levels, and neuroimaging studies are performed to check for other treatable causes of dementia. If clinical findings suggest another underlying pathology, for example, HIV or syphilis, tests for these conditions are indicated. These findings increase the likelihood that dementia is due to Alzheimer's disease. However, guidelines do not support the routine use of these biomarkers for diagnosis because their standardization and availability are so far limited. Furthermore, the guidelines do not recommend routine testing for the ApoE4 allele. Differential diagnosis. Distinguishing Alzheimer's disease from forms of vascular dementia can be difficult in some cases. The modified Hachinsky ischemic score is sometimes used to help distinguish vascular dementia, primarily multi-infarct dementia, from Alzheimer's disease. In any case, it's better to perform a brain MRI. Key features can help distinguish Alzheimer's disease from multi-infarct dementia, a type of vascular cognitive impairment and dementia. See table for differences between vascular cognitive impairment and dementia and Alzheimer's disease. Fluctuations in cognitive state, Parkinsonian signs and symptoms, well-structured visual hallucinations, and relative preservation of short-term memory suggest dementia with Lewy bodies rather than Alzheimer's disease. See table for differences between Alzheimer's disease and dementia with Lewy bodies. Patients with Alzheimer's disease are often better cared for and characterized compared to patients with other dementias. Initial evaluation in subjects with suspected dementia. Conduct a thorough anamnesis of the person to be evaluated, possibly with the help of a family member or someone who knows the patient well, both to understand the period of onset and the characteristics of the symptomatology, particularly memory and any behavioral disturbances. In any case, perform a general and neurological objective examination. Request blood tests and cognitive tests, including the mini-mental state examination or more complex neuropsychological tests. Also evaluate the negative effects of anxiolytic drugs or major tranquilizers and possibly identify any reversible causes, such as depression of mood. If Alzheimer's disease is suspected, consider examinations such as FDG PET, fluorodeoxyglucose positron emission tomography, or perfusion SPECT, single photon emission computed tomography. Examination of cerebrospinal fluid to search for tau protein or beta amyloid 1-42 or 1-40. Safety and support measures for Alzheimer's disease are the same as those used for other forms of dementia. For example, the environment should be bright, cheerful, and familiar, and should be designed to reinforce orientation. For example, placement of large clocks and calendars in the room. Measures must be implemented to ensure the patient's safety even within their home. For example, monitoring systems with signals for wandering patients. It is also important to provide assistance to healthcare personnel or family members themselves, who may be under considerable stress. Nurses and social workers can instruct caregivers on how to meet patients' needs. Professional figures or family members themselves must identify any early symptoms of stress and psychophysical exhaustion of the person assisting the patient, and if necessary, indicate support services. Prognosis of Alzheimer's disease. Although the degree of progression varies in patients with Alzheimer's disease, cognitive decline is inevitable. The average survival from the time of diagnosis is 7 years, but there is no consensus on this aspect. The average survival from the time patients can no longer walk is about 6 months. End-of-life issues. As self-perception and judgment capacity reduce over time, patients with dementia may need to entrust financial management to a family member, guardian, or lawyer. In the early stages of dementia, before the patient becomes totally incapable, it is necessary to clarify the patient's wishes about the type of care they want to undergo and the management of legal aspects, for example, testamentary dispositions, provisions relating to medical care. When these documents are signed, the patient's decision-making capacity must be evaluated, and the results of the evaluation must be recorded. It would be advisable to make decisions in advance, before the need arises, about the use of artificial feeding and treatment of acute illnesses. In advanced dementia, palliative measures might be more suitable than highly aggressive interventions or hospital care. However, there is no convincing evidence that people who do not drink alcohol should start drinking to prevent Alzheimer's disease. Once dementia has developed, it is usually recommended to abstain from alcohol consumption as alcohol can worsen the symptoms of dementia. Final considerations. Even though genetic factors may be involved, most cases of Alzheimer's disease are sporadic. Differentiating Alzheimer's disease from other causes of dementia can be difficult, but it is often best done using clinical criteria that have an accuracy of 85% in establishing the diagnosis. Treat Alzheimer's disease similarly to other forms of dementia.